Good afternoon, everyone. It's a pleasure to welcome you to the second in this series of the Health in the Public Interest Zoom seminars for the fall semester at Georgetown. Adrian Fu Berman, who is also on the seminar, and I are the co-directors of that program, a program that emphasizes social determinants and other non-clinical determinants of health. And we're going to get to a subject right at the heart of social determinants today with Annemarie Jutel. But before we do that, let me tell you a little bit more about how we're going to run this program. So, first of all, we have in the chat, or we'll have a link to our program if you want to see more about it. We welcome you to go and look at our previous seminars, to look at the program activities, and send us any comments or questions that you have. So, the seminar will run as follows. So Annemarie Jutel, who is joining us in the middle of the night from New Zealand, is going to be speaking for roughly 40 or 45 minutes, and it's up to her how much she wants to draw you all in or engage you during the talk, but we're going to preserve lots of time at the end up until 1:15 p.m. Eastern for questions and answers and discussion. And we hope that all of you will take part in that, but we take questions first from students and then from the general audience. We have a student moderator who's going to introduce Anne-Marie in a second, and then he'll be the one who also moderates the questions and answers and such. So Gerard Bisimwa, take it away. It's all yours.
Thank you so much, Dr. Adam. Um, Good afternoon, everyone. Very excited to see you all here. Today I'm gonna be introducing Dr. Annemarie Jutel. She's a professor of health at Te Herenga Waka, Victoria, University of Wellington, New Zealand, and she's achieved full professor status in 2016. She's a leading psychologist in diagnosis, whose research examines how social and cultural aspect of the experience of health, illness, and disease. One fun fact our uh, about Dr. Jutel today will be she was the first girl in the state of Virginia to run high school cross country. And guess what? She was in the boys team. So she was definitely a pioneer today. I'm very excited to hear everything about her. So thank you so much. Please go ahead. The floor is yours, Dr. Jutel.
Kia ora e merci, Jero. I'm ka nui te koa ki te kia koutou in Māori, the indigenous language of the country in which I'm sitting. Thank you so much. It's lovely to see you all today. And particularly, there may be more than one person that I know, but hello, Leonore. Lovely to see you. I noticed your name, and there are lots of screens. Hello, Barbara Marshall, whoever you are, with your beautiful graphic version of yourself. I'm also a cartoonist. And one small correction, Giro, sociologist, not psychologist. But hopefully, actually, I was going to say, hopefully I don't alienate too many psychologists. I am currently working on a anti-psychologization book, which is discussing psychological diagnoses and whether we're overusing them right now, deploying them for reasons that maybe we could use other languages of suffering, as Sven Brinkmann, a famous psychologist, once said. So I'm going to try to do some screen sharing. It is 4 a.m. Maybe slightly awkward, so if you'll bear with me, I'm first going to see if I can share, which I can, and then I have to find the right screen, which is there. Share, and then I need to project this screen so that you don't get confronted by my notes. Let's see if that works. Slideshow. Oh my God, it's working. So I think, oops, sorry. Yeah, okay. That was just me doing a test run. I think I'm ready to go, and I didn't let you settle on my title slide. I hope you'll forgive me for that. I'm starting with this quote from Mary Douglas. She's an anthropologist of the old school, so forgive me for using old school anthropology, which is fairly colonizing. However, in her book, Purity and Danger, she said something that I like to quote because I think it's fairly powerful. What she said here is, it may seem impossible for a person to shake his own thought free of the protected habit grooves of his culture. All those pronouns, forgive me for those as well. How can he turn around upon his own thought process and contemplate its limitations? And I think this is an important thing for anyone in an academic field to be thinking. How can we look at the tools of our analysis, the tools of our reflection, and get some critical distance from them? Because the tools that we use to understand the world, hard to put them down. You can't use them to understand your world. And this is why I propose using other disciplinary perspectives on diagnosis, our clinical, our epidemiological, our tools, our most dominant tools in understanding health, illness, and disease in Western countries. How can we put down diagnosis and look at it from afar? How can we obtain some critical distance? And this talk is trying to show precisely that by using a non-health lens. So this is sociology, although it's more than sociology. I think I call myself not a sociologist of diagnosis anymore, but a critical diagnosis scholar. But I think that you get critical distance from your subject by using other tools of analysis to explore it. So it's a defamiliarization that I propose to offer you in this lecture. I think you probably are more distanced from diagnosis as tools than many. Otherwise, you probably wouldn't be in a class like this or in a meeting like this. But I'll show you my way of being critical of diagnosis and making it a more powerful tool, in fact. So Ian Hacking said, and Ian Hacking, a philosopher, I think Toronto, Canadian in any case, wrote, from at least, sorry, typo, at least the time of Aristotle, the idea of nature has served as a way to disguise ideology, to appear to be perfectly neutral. No study of classification can escape the obligation to examine the roots of this idea and to see how it has served different ideologies, even to the present day. And no study of the word natural can fail to touch on that other great ideological word, real. So once we study nature and make our classifications and say that this is what nature is, it becomes unrefutable. And when we can no longer refute, ideology is, of course, being deployed. So classification is a way of shutting down argument, even though we may not realize that we're arguing. And that's also part of what I will reveal as we go along, how classifications are made in a particular way that sees one world as real and fails to see all the other options which might have been available before they got cemented into categories. And what is diagnosis but a man-made category? So before I go much further, I want to make sure that you know this is not an anti-diagnosis talk. And while that's supposed to be me, as my graphic novel says, my cartoons can't keep up with my haircuts. That's what I used to look like. And my glasses used to be blue. But that's the kind of work that I do. I'm a rural first responder. And when someone calls the equivalent of your 911, it might be me who would go out in my truck with my bag of supplies and my intubation kit to try to figure out and keep someone from dying. Now, it's interesting, I'll just digress a bit from my notes. I'm trained by paramedicine to do this work, and there are huge debates raging in paramedicine. Do we diagnose? Do we not diagnose? No, we don't diagnose. We triage and prepare for transport. Wait, no, you do diagnose. No, we don't. Yes, you do. Anyway, there's some very important work that takes place in the catastrophic setting. Whether or not that's an ectopic pregnancy or an intoxication matters for the survival of the individual. And therefore, number one, my argument would be, yeah, you diagnose. And the other thing that I really wanted to make as a point is I believe in diagnosis. It is a critical tool in our clinical work and in our epidemiological work. But it's got its rough edges. Okay, now, the big question, if we go back to hacking and try to figure out whether things are real, is, are diagnoses things or are they ideas? We'll take a look at that. So diagnoses are consensuses. And someone can go check if that's a plural of consensus, but I think it is. Debates among learned people. Papers are written, discussions are had, and diagnostic categories are agreed upon. So disorders don't come out pre-labeled. They have to be seen, recognized, circumscribed, defined, cemented. So I don't know, is a consensus real or is it a thing? I think we're going away, or I, in my thinking, going away from the fact that a diagnosis is ontologically thingy. Rather, it's a human process, or it's a result of a human process. And the issue of being seen first is an important part that I want to stop and talk about for a moment. So things do have to be seen before they can become things. And I've put a microscope up there, but the microscope is a metaphor. It's not that they necessarily have to visually be seen, although that little COVID pomodoro underneath would be an example of one that did have to be visually seen, or that was visually seen. Well, even COVID. Okay, so COVID is a thing and we could see it and we knew we had to see it. But imagine COVID could have first taken place on some isolated farm amongst really strong young adults who got a bit of a cold, even though it was alpha, and then got better and then never went anywhere. Well, it would never have existed in our clinical minds, even though it was very thingy, it never would have been seen. So seeing probably is more important than thinginess. We could talk about a psychological diagnosis, but what I was going to say to my psychology friends, and I imagine there are a few on this call, psychological diagnoses are low-hanging fruit. I prefer, if I can, to use physical diagnoses because it's really easy for us to fight and debate over whether psychoses or schizophrenia or bipolar, you know, what categories do we have here? And we've seen the big changes in the DSM over time. So disagreements or changes, evolutions in the way we have seen psychiatric diagnosis, but it's too easy with psychology. I want to make it harder. I'm going to mainly use physical diagnosis because I want to show that even with physical diagnoses, which are much more thingy, they're not that thingy after all. It makes my argument stronger, I think. But the one, how about dyslexia? Dyslexia is a thing, but you couldn't see it in a non-literate society or in a society where reading wasn't valued. So it just wouldn't be a thing. So you have to be able to see. Going back to the consensus idea, we see things through, things through lots of different lenses, but we become aware of things through human interaction, through pride, through technology, through stubbornness, through conflict, through all sorts of interesting other phenomena that are not necessarily clinical. If we go to some examples, I do have the microscope there because some things actually have to be visually seen. And I hope you've read Wailu's work on blood because it's fascinating work. And things like sickle cell anemia couldn't have been differentiated from other systemic diseases before the arrival of the blood smear. If you couldn't see it, how could you know that there was a sickle cell? But look at all these people. So all these four images. I want to walk through the first all of them for you. Upper left-hand corner, Zach Guilford, very promising young rugby player, drinks a lot of alcohol, drinks way too much alcohol, just drunk. Actually, I should say that when he was at the World, and there may be rugby fans in this room, but rugby is of my nation. It's our national sport. And Zach's father followed him to the under-20 World Championships. I don't remember where it was, probably South Africa, and then had a heart attack in the stands and died. So while he was playing for New Zealand in his first big event, his father was dying in the stands. And this guy drinks a lot. He drinks so much that he can't play rugby anymore. And that was variably seen as a discipline problem, as a disease. And of course, if you look at the history of addictions, and maybe actually even the first mention, as far as I know, of the sociology of diagnosis was by Mildred Blackster in 1978, and her case study was addiction. So disease diagnosis depends on the era, depends not only on the era, but the disposition of those talking. So Zach, who I speak about familiarly, but I don't know him. He's just a familiar word in New Zealand culture because of his very visible engagement with alcohol. What do we see when we look at Zach? But what would he see when we look at William Fox Napier, the cardinal on his right? He's a South African cardinal who believed, I don't know if he still holds this stance because he got in trouble for it, that pedophilia is a disease. And so we see pedophilia is a crime against children, and we put people in prison for it. And his argument was that it was really a disease and people needed support. That's understandable. How do we see it? What can we see when we look at that? When we look at a despicable behavior to social standards, are we going to call it illness or are we going to call it crime? It depends on what lenses we're wearing, in what era, from what era we're speaking. Certainly, there are many other criminal behaviors which are permitted or not permitted, are forgiven when they're given diagnostic status. So what do we see? What does he see? That's another example of how seeing may affect what becomes real. Underneath that slide is of Lyme disease. And I'm going to say that Lyme disease, if we look at Robbie Aronowitz's history of Lyme disease, was something that became visible because of geography. And why did it become visible? Because of geography? And forgive me, anyone from Lyme, Connecticut, if I mischaracterize your town, but my understanding is that Lyme, Connecticut was an affluent small town in Connecticut where mummies didn't work and stayed with their little kitties and noticed that Johnny's bullseye rash and Susie's bullseye rash resembled one another because these were educated mummies. They talked to the doctors listened to them. Because of that, Lyme disease was visible to a community who could then make overtures to the CDC and who could then determine that there was something going on here. So Lyme disease exists, and it exists because of a geographic accident. I can't imagine Lyme disease having been discovered in inner city Harlem. There would have been racist and demographic and a whole range of other barriers to the visibility. So again, the microscope is a metaphor for seeing. The Lyme disease, that microscope or that image would always have been present, but that doesn't mean that it would have been seen. And then the very last, that adorable little bubby at the end is there because he is diseased. He has Down syndrome, and that's treated like a disease. We see it as a disease. I think it was in Ireland where they want to eliminate Down syndrome. So the pre-screening is all about making it go away. There's so many beautiful people with Down syndrome. It's a problem and a point of contention. But then by the same token, that little bubby probably needs some extra resources, and his diagnostic status gives him access to stuff. So having a diagnosis opens doors, and saying that's not a condition would probably have both positive and negative impacts on that small child. Next slide. So there you go. Back to our example of pedophilia. This is a question about deviance. So the sociological meaning of deviance in shorthand is really, is it outside of the norms? Deviance means, well, we think deviance in sort of colloquial speak, we think deviance means the guy on the right, the sort of evil, bad person, but it really means being different from everyone else. So the Down syndrome baby would be deviant in the sense that, not that he's evil, but that they are outside of expected norms. And the question of deviance affects probably all aspects of, I don't know, range of motion, cognition, fitness, mobility, sight, hearing, just all aspects of our life. When you're outside of the norm, which is the middle of that U-shaped curve, you're deviant. So when we look at deviance, do we look at it and say, oh my God, that's a bad, evil? Or do I say, oh my God, sick? Many, and I think, give me a minute. Having a brain dump, it'll come back to me. There's been The Tyranny of Diagnosis. Rosenberg has written a nice piece in Perspectives in Biology and Medicine, where he talks about how a diagnosis guards that boundary between normal and abnormal and determines what social stance we will take towards the individual who has some deviant behavior, function, or anything else. So if we think, we talked above about alcoholism and pedophilia, but it could be anything: ADD, ADHD, chronic fatigue syndrome, psychotic delusions. Are they sick or are they bad? That's how sociologists would look at it. But Thomas Arnold, he was the headmaster of rugby school, and that's where rugby got made. And this quote floated at me one day many, many years ago, and I've stolen his version of it. But many people and many thoughtful philosophers and so forth have talked about how nature is divided at the joints. And he said in 1839, we are not to suppose that there are only a certain number of divisions in any subject, and that unless we follow these, we shall divide it wrongly and unsuccessfully. On the contrary, every subject is, as it were, all joints. It will divide wherever we choose to strike it, and therefore, according to our particular object at different times, we shall see fit to divide it very differently. So when we divide, we can divide here to classify something as X, or we can classify it as Y. There's so many different ways to take an object and see it. And here's an example that I love to use, again, because it's a physical diagnosis. This is gout. Now, gout has been around and understood for a very long time, centuries. I think colchicine, which is the main, well, I think it's colchicine. I don't know, I'll get corrected. But colchicine has been used to treat gout for centuries. So gout, for those of you who don't know, is a defect in the protein metabolism, which leads to a byproduct of uric acid accumulating in the blood, and it's kind of sharp crystal stuff, and it settles in joints and it hurts badly. It also settles in kidneys and hurts badly, but it's a very sore, a very awful thing. Now, it used to be the disease of kings, probably because they got more protein than other people. But look at those different potentialities. Is it because you drink too much and eat too much? Is it because your DNA, you're genetically predisposed? Is it because of colonization? Those bloody Brits and French and Belge came and brought from the Congo Giro. I'm sure you'll have a perspective on that. Certainly in our Polynesian islands, we do, because there was a replacement of food by these colonizing forces. And what happens when you eat mutton as opposed to snapper? Maybe you get gout. That seems to be what's happening here in Oceania. But then there are also other questions. Is this a rheumatological disorder? Is it an endocrine disorder? Even a diagnosis fixed for such a long time is a very debatable diagnostic category. And of course, in our country, I was on a gout study once. It was just such an offensive study. It was I was asked by a rheumatologist to come do some work with his Pacific men, usually also a male problem. And of course, there was an assumption by this redheaded white rheumatologist that they were drinking too much and eating too much. And it's so not the case. It was such a problem of nutrition and availability of proper nutrition, and probably centuries and centuries of eating different kinds of food. So the cheap food in the islands and the cheap food in New Zealand are not the same things. So fairly interesting. We could also consider, and I'm just gonna, Adam, will you stop me if I go on too long on this one? The whole HbA1c pre-diabetes thing. Yeah, thank you, Adam. Okay, because this is I'm on a hobby horse on pre-diabetes right now. So we have cutoff diagnoses, right? And diabetes is a cutoff diagnosis. If you have a glycated hemoglobin of over X, and in our case, we count in millimoles, and that would be over 50, you're diabetic, and it goes on your chart, and there you are. But early 2000s, there was this idea, American Diabetes Association, that we should have this new category called pre-diabetes, and that would be for people who didn't meet the diabetic standard, but who had this HbA1c measurement that was slightly elevated. Now, HbA1c is it's related to the hemoglobin, and what happens, the hemoglobin, which is the red oxygen carrying part of the red blood cell, lives for about 120 days, and it gets coated with the sugary stuff in your blood. And so it gives, this test gives you an idea of the sort of ongoing blood sugar management, as opposed to the finger prick, which gives you the immediate, what is my blood sugar now? What did I have for breakfast? How does that influence it? So this became a very convenient way of measuring and categorizing and putting people in this place, which from a public health perspective might have logically looked intelligent. If we monitor these people, we can keep them from going across that limit. There's no evidence that someone who has in that this pre-diabetes zone is going to slide into the diabetes zone if they don't have other risk factors. So the blood test has been very controversial if people are paying attention. It has incited many people to go on diabetes medication before they reach the diabetes cutoff to try to lower this number that maybe was never going to climb anyway. But the scandal right now is that there are 2 labs in New Zealand who've been misrunning their assays. And people came up diabetic and pre-diabetic that hadn't been before. For 4 months, they were getting numbers that said, aha. So we've got this, it's a scandal. And I'm caught up in it both as a patient and as an advocate. Is it a scandal that the numbers were wrong? Well, yeah, they shouldn't be wrong. Is it a scandal that we have this category and that all these people are terrified and going on draconian diets when nothing was wrong with them? Yeah. Is it a scandal that we use a number in this pre-diabetes category as clinicians, as my doctor did, to determine whether we can trust our patients or not? So if a patient says, my God, I bike 10 kilometers a day, I eat a beautiful diet of unprocessed food, there's no risk factors in my family, and for the doctor to think, nah, I don't believe you. You eat too much pasta. His words exactly. So this is an interesting diagnosis. I'm going to stop now, Adam. You don't have to control me anymore. Which designates fault. Right? You should be able to do something about it. You have a moral obligation. You ought not to have gout. You ought not to have lung cancer. You ought not to have diabetes. So the diagnosis has tremendous power to stain us, to stain the patient, to assign responsibility. for lifestyle diseases. So large body size, even miscarriage. Miscarriage. You dropped the baby. In contrast to, say, stillbirth. And where do we determine the distinction between miscarriage and stillbirth? At some unviable number anyway. Like, it depends, because every state, every country will have a different standard, but I'm guessing for most of you, the cutoff between stillbirth and miscarriage is something like 21 weeks, which wasn't survivable anyway. So if it was 21 weeks, why not make it 18? You know, someone decided. And actually harkens back. Let me interrupt myself. What I didn't say to Géraud was when I ran cross country in Virginia. It was a long time ago. I was going to make that be a contest so you could figure out when I was a high school kid in Virginia. But when I was a nursing student in France, which was also a really long time ago, I can remember the birth of a 28-week child. And I can remember the pediatrician giving at rounds saying, this is a failed miscarriage, because he didn't think the baby was going to live. So within living lifetime memory of this, not that old woman, 28 weeks would have been the line between survival and non-survival. So miscarriage stains, it implies something, and as do many other diagnostic categories. So one of the most important social consequences of diagnosis is what it says about your character in relation, what it erroneously, says about your character in many cases. Now, a diagnosis is shorthand. So what it does is it says in one word something that would have taken lots of other words to say. So if we go back to the problem of gout, instead of saying, oh, I have a problem metabolizing protein, which makes sharp uric acid crystals land in my joints and gives me lots of pain and incapacitates me, you can say, I got gout. And your doctor will understand, your friends will understand. They may have to look it up, but everyone understands. It's shorthand. It's a really good way of communicating effectively almost anything. Influenza, I have fever, body aches, respiratory symptoms. I've got the flu. So we use diagnoses as a short way of explaining what's going on with us. And while the shorthand is effective, they're often very facile diagnostic stories that we put with them, like gout. You eat too much. You drink too much. Pre-diabetes. You eat too much pasta. Lung cancer. Did you smoke cigarettes? I think right away we have to understand that a diagnosis can be flattering or stigmatizing, but it underscores just how social a diagnosis is because of all the associations which come with it. Let me give you an example. You have a rash. So you could say something complex about the nature of the rash. You're probably just going to say, I have eczema. Easy. Or I have scabies. Which one do you want to say? The impact of saying I have scabies, I have eczema, really different. Treatments, very similar. Okay, so you got to go wash your sheets with scabies. You've got to do that kind of thing. But you're going to put a cream on you. You're not going to share it with the people at work. It doesn't jump on people with whom you don't have intimate relationships. But if you go to work and say you got scabies, you're going to get a different reaction. So that's how diagnosis works socially. Now, there are also diagnostic hierarchies, and I guess all of what I'm talking about right now alludes to it. Be better to have eczema than scabies. Here's eczema, here's scabies. But it goes more broadly. Chronic fatigue, as one example, has been at the bottom of the hierarchy of diseases for a very long time. Oh my God, wait, I just have to make sure. No, I can't. I'm not sure if I can say this. I reviewed a paper recently about medically unexplained symptoms that I found completely abhorrent. And without getting into the topic of medically unexplained, into the topic of the paper, because that would be unethical, the thing about medically unexplained symptoms is, while that sounds like a very neutral sort of term, something that medicine can't explain, that's not actually how it's deployed in medical speak. When we talk about medically unexplained symptoms, we're usually saying psychosomatic symptoms or functional disorders, things where we don't know what's going on. So it must be in the patient's head, because if it doesn't fit into the classification system, these are just stressful patients to us, the clinicians, which to me, as I said, abhorrent, because people suffer. And if medicine can't find the source of their suffering, we shouldn't put it into a psychological wastebasket. Sometimes it is psychological, but to say all that we cannot identify by medical means is psychological is to disrespect patients. And of course, chronic fatigue, ME, and fibromyalgia have been very irritating to medicine, and for many have been seen as psychological disorders, malingering, that sort of thing. And then long COVID came up. And long COVID is too prevalent for us to be able to close our eyes. We can see it. The question is, for me, I'm sure it's a similar post-viral syndrome that we've been observing for decades in our fibromyalgias and our chronic fatigues. And the fact that they're different presentations is, as we know, very typical of long COVID, because some people come to long COVID with brain fog, others come with post-exertional fatigue, others come with, a range of problems. So this is an interesting moment where fatigues are in the balance, and where we may start seeing different ways of thinking. I hope so, because lots of people suffer. But there's a wonderful Norwegian scholar, Dag Album, who's done work on disease prestige. And I really think he means diagnostic prestige. We had a good conversation about that. I'm not sure I convinced him, but he did do some important work. This was amongst clinicians, but I think we can do it amongst anyone. Where do diagnoses sit in terms of prestige, and what does the prestige or lack thereof do to the experience of those suffering from or being labeled with these diagnoses? Because we suffer from disease and we get labeled in a particular way, and how we get labeled affects the social experience of that disorder. Now, diagnosis is linked to a lot of stuff. Usually when you get a diagnosis, you get an explanation, you get a treatment, you get a prognosis. What's interesting about that, and I did a wee study with a group out of Philadelphia. I wasn't there, I was over here, and they were there, and they were interested in people who left the emergency department without a diagnosis or without a pathological diagnosis. So they came in and said, oh, I got a sore back. And they got ticked with sore back. And when they left, it said sore back, which meant they didn't actually have a diagnosis. They just had a description. And we wanted to understand how they felt about that. What was really interesting is that those who felt they'd gotten an explanation, a treatment, and a plan thought they'd been diagnosed. So actually, it's maybe not even as much the diagnosis, but it's trappings that we need and want. Now, that's not the end of the story. That's just part of the story. How do you get a treatment if you don't have a diagnosis? Do you just do it empirically? Oh, why don't we try this? Or we could try that. I think you have X. The proper treatment is Y, because we've done studies, we've got categories, we've got classifications. We can do research when we put things in boxes. But it also comes, those were nice things to get from diagnosis, but it also can come with stigma and marginalization. So that's another gift that diagnosis can offer. And it can also offer what I've tried to draw here, exploitation from the wellness industry, from direct consumer advertising, from self-help, from pharma, from for-profit medicine, from you can just imagine. And I'm probably certain that you modern people, like the modern people I know and like myself, as soon as you get a diagnosis, you go looking to see what's on offer. And you may get exploited. You'll probably get exploited. We mainly get exploited, and particularly if you have a tenacious condition for which there isn't a treatment or for which the prognosis is poor. So the diagnostic process is also important, an important social moment, because there's a kind of tug of war going on there. There's a power, there's power in play in the diagnostic process, because diagnosers have social prestige. And why do they have social prestige? They have social prestige because they have the power to name normality and dysfunction. They're the ones who say whether it's scabies or eczema. They're the ones who decide what counts as sick and whether you're going to get to have leave or a treatment or sympathy. They're the ones who can render visible your suffering and legitimize your suffering. So naming is a superpower. And let's imagine who those people are pulling on the rope. On the one end, we have the traditional medical clinician. On the other end, we have other allied health professionals, nurses, nurse practitioners, patients, industry, everyone who wants access to that superpower. So, little thought experiment. What would healthcare, public health, individual health look like without diagnosis? What would you gain? And what would you lose? Really important. I think my last slide will give you all these references, but if it doesn't, ask me and I'll provide them. There's a wonderful paper by a linguist named Suzanne Fleischman, I am, I have, I suffer from. And she writes about her own hematological diagnosis. It's very powerful and very interesting. If we didn't have a diagnosis, how would we feel about not feeling well? If we didn't have a diagnosis, how would we undertake a randomized controlled trial to find out if such and such therapy is safe or not safe? If we didn't have an experiment, how long would it take us to get to explanation and cure? If we didn't have a diagnosis, on the other hand, we wouldn't be summarized in the same way and perhaps forever tarred by the words written in our charts. So boxes are really good for putting things in. They're not that good for living in, but I can't imagine healthcare without diagnosis. On the other hand, I can imagine some advantages to defocusing on the idea of the category for explaining what ails us. So the next slide is Jutel's social model of diagnosis, which tries to encapsulate, oh, sorry, that's gotten unformatted, but it tries to encapsulate a bit the way diagnosis operates as a circular relationship. On the one side, we have the social frames of diagnosis. Disease discovery is sort of the, how do we see something? How does something become visible to us? What are the classification systems that we have available to us? What are the technologies and what screening do we undertake? HbA1c, we screen for that. The diagnostic process in the middle, which I don't go into much in that little picture, but there's a lot to be said about who gets to, how does it happen, who is believed, whose words counts. And on the other side, the social consequences of diagnosis. You get stuff, resource allocation, but you get legitimization and your condition gets rendered visible, but you also have exploitation and stigmatization, all of which feeds into the circular relationship of how do our social frames change over time in order to respond to the consequences of diagnoses. So that's kind of in a nutshell, this thing, is it a thing? This idea called diagnosis, and how I conceptualize it critically as a sociologist who uses diagnosis as a clinician, and who writes about it extensively. Putting a name to it, Diagnosis in Contemporary Society, Sociology of Diagnosis, A Brief Guide, and Diagnosis, Truths and Tales. Those are my books. I've got a bunch of articles you can read as well. And here's kind of a reference list of things you should read, but I see it doesn't have Fleischman in it. So I might update that and send that back to the team in case you guys want me to circulate it. And on that note, I'm going to stop talking. And if I can find, I have to move things around on my screen to stop sharing. And I can't make that work right now. There we go, up the top. That's me. Okay. Over to you guys. Questions, comments? Kia ora.
Kia ora, Dr. Jutel. Thank you so much again. So we'll be proceeding to the Q&A section, and I'll be prioritizing my colleagues before the general audience. And okay, we can proceed with June. I can see a couple hands already.
Hi.
Hello,
First of
June.
all, oh, sorry.
You go.
Yeah. Hi. First of all, thank you so much for your talk. It was super interesting, and like made me think in a different way that I haven't thought about diagnosis before. I was just wondering, kind of in regards to the thought experiment that you proposed, as I was thinking about it, I was almost wondering if you have any thoughts about the role of diagnosis in almost like I'm trying to think of the best way to say this, almost like narrowing down the stigma of a particular condition to like a particular group of people. Like I was just thinking about your example with the eczema and the scabies, and like in that context, so like if we didn't have diagnosis, would like every rash that you have kind of lead to this stigma of like, oh, don't go near them, like that could catch? Or do you think that like diagnosis has any role in either broadening or narrowing stigma in that way?
I don't know. That's why it's a thought experiment, because I hadn't thought of that. Everyone becomes a leper in that model, perhaps. So yeah, one of the disadvantages of not having a diagnosis. Yeah, no, I mean, your own answer, June, really. I think that's a good point to make. And when you see a rash, you go, oh, it could be scabies. So, yeah.
Thank you.
How about?
How about
Yeah.
Sid?
Yes, hi. Thank you so much for speaking with us. This was a really insightful lecture. My question was actually very similar to June's regarding stigma, but we actually spoke about this like power of naming during our summer class, and how like specific vocabulary surrounding even like things like the reproductive system, it can very much change the way how we personify certain medical like things,
Yep.
for lack of a better
Yep.
word. How it can like
Yeah.
change the way we perceive things, or how we understand processes. So I guess I couldn't prepare another question on the spot like that, but would you say that this like hierarchy of diagnosis, is this like a reason for exacerbating stigma, or are there other barriers that it can lead to things being overlooked in society?
Yeah. Well, I'm not really in favor of not having diagnosis. Like I'm in favor of diagnosis. I think it organizes how we provide care in a really careful way. There are lots of disadvantages to it, however, like if you most doctors are using, computers to write their notes now. And so they have drop-down menus and categories from which they have to choose. And sometimes it's really complicated. I actually, I went to the emergency department once because I'd stuck a flax frond in my eye when I was gardening. And there is no category of stuck flax frond in eye. Was it a puncture of the cornea? Well, no, it wasn't really a puncture of the cornea. Was I supposed to have gone to the doctor? Yeah. I needed to go to the doctor. I actually needed, I don't know if I needed drops or something to soothe it. But there wasn't a category in which to put it. And as the doctor explained, in the past, he would have drawn a picture. He would have drawn a picture of the eye and he would have said, flax, frond, poked eye there. wasn't necessary in that case. But I think, and actually, so trying Suzanne Fleischman, the linguist's work, I think is fairly interesting and important as we think about how we refer to things. Do we become our diagnoses? As the heart attack in room 21. With respect to the language of the sort of naming and blaming and how we talk about medical things. Of course, you should read Metaphor, Suzanne Sontag's Illness as Metaphor, but also Emily Martin, who wrote something, I can't remember, HIV, AIDS is in the title, but she talks about the metaphors that we deploy. Actually, maybe I've got that wrong. Emily, sorry, it may not be in that book. Emily Martin, who's a cultural historian, talks about how we reproduction, language of reproduction, and when we talk about menstruation versus spermatogenesis, and menstruation is usually referred to as a failed conception, whereas spermatogenesis and ejaculation is talked about as this marvelous thing, when in fact it's full of waste material as well. It's not just sperm and the ejaculate. So languages that we deploy, whether they're diagnostic or not, shape what we can think about things in our bodies and in our well-being. Yeah.
Kia ora Abba for this question. We'll go with Taruni.
Hi, sorry. Thank you so much for your talk. Yeah, I know Molly mentioned it in the chat, but we did read one of your articles in one of our earlier classes, so it was really interesting to hear from you in particular. My question was a bit more generic. So we were kind of talking about in our other class about how they broadened the definition of hypertension. They lowered the level recently. So I'm curious how different societies kind of define or approach the pre-disease states. So is it different in certain communities? Because this hypertension change was with the American Heart Association. So with pre-diabetes or things like that, does it vary a lot between societies?
That's a good question. And you're thinking, I could say between the US and New Zealand, there are some differences in our cutoffs. For example, our diabetes cutoff is higher than in much of the world, but I can't, we talk in millimoles and you talk in percentages, so it's hard to compare that. But I think actually, Giraud, where are you? I think it's probably more interesting to look at questions like African nations and Polynesian islands. And I think when we think about medicine as being, medicine is the West. That's where it came from, but it's used everywhere. What happens when you go to Papua New Guinea? And really big different things. So there's huge variation in countries, if we think of countries as being more than just France, Canada, the US, and New Zealand, Australia. But I don't know, I actually don't know how much, if you look at the ICD, you have different revisions in different countries. And as I said, we've got different diabetes cutoffs, but generally it's the same trend. And wherever it starts from, it goes broadly, but only as broadly as this first world concept of nation that probably many in this room are familiar with. Is that, Giraud, can you help me there? Actually, can I just ask you, in Congo, what would it be like? Do you have an idea of that yet or not?
I do. I can say regarding I'm just gonna say about it globally. I would say Central and Western Africa, it's definitely more about the community. When someone is sick, everybody else is sick, and everybody else can be affected directly by it, if you see what I'm saying. So if a household, for example, is definitely affected by, let's take a quick example, maybe diabetes. Everybody else's diet will change in the household, or maybe dad will have different ingredient for every single meal he will have. He will have every single dish is prepared only for him. On the other hand, everybody else will be eating something else, you know? Or in a different way, we can see that everybody else would like to contribute to the well-being of the dad who's probably sick. And same thing for the mom. It's actually worse, I will say, if a mom of a family is sicker because it's the entire equilibrium of the family that's crumbling down. I hope it does make sense.
Yeah, well, and I was going to say something else just comes to mind while you're talking. One of the things, because I was trying to think why I was having such a hard time answering other than in that sort of broad conceptual way. And it is because I don't work in public health. And I was thinking, well, this is a question for public health. But then I thought about, here's an example, BMI. So BMI, which is may I say, it's a public health measure. There's something called the ecological fallacy. The ecological fallacy means that you can't take this population measurement and apply it to individuals. So I'm not a fan of the BMI in the individual health consultation, but it is used. It's used broadly. But it's made, I don't know how they came up with it, boiling up fat white American men and finding out how much fat they had on them. What we do know is that it is not actually measuring adiposity. And when we look, there's only one Polynesian nation which has been specifically studied for adiposity in relation to the BMI. That's Tonga. And in Tonga, yes, it is Tonga. And in Tonga, they found lower adiposity at higher BMIs than in our standardized BMI charts. Okay. And then if you go to India, I think they found higher adiposity at lower BMIs. So it's population specific, but I don't know what they've done in the Congo. I do know what they haven't done in Polynesia. And in our countries, in public health initiatives in New Zealand, always look at the BMI of these, Cook Islanders are the fattest people in the world. No, that's not true. It's just that this tiny nation has not been, is being measured to white man standards. And I think it is, I don't know if it's white men. I like to say white men. That may not be so. It may just be white people. Yeah, I know. But and the example, I use this in my very first day of my first year class. There's this beautiful rugby player. He's now retired, named Aaron Smith. He's a halfback. If you follow rugby, you'll know that a halfback is a little guy. I am the same height as Aaron Smith, and he plays for my favorite team. And he was the best halfback in the world. And if we use BMI as a standard, we should be the same BMI, right? So me and Aaron Smith, if that's our measurement of health, I weigh 60 kilos, he weighs 80 kilos. Oh, wait, I'm fine, he's obese. Because it doesn't take into consideration his muscularity and his Māori, his Polynesian status. So yeah, so I think actually that probably, Taruni, gives you a little bit of an idea of the non-transportability and yet the imposed transportation of some of these diagnostic categories. Is that fair enough?
Yeah, thank you.
Kia ora Tarun. The next question I'll be taking from the chat. So Noah asked how do you feel that the COVID pandemic has changed or shifted the sociology of diagnosis?
That's such a good question. A lot. I've got long COVID in my household. So I would say I've got long COVID in my household and I've never had COVID. And I share the bed with a person who has long COVID. So, my hoarangatira, my husband. There's so much which has come up about patient-doctor relationship through this misunderstood or this poorly understood disease category, diagnostic category. There is so much that comes up in relation to the contested, exploitative legitimacy. There's so many of those things in that model that get reinforced. So the COVID pandemic has helped to solidify, I think, thoughts about diagnosis. I think I have a slide that I use in some presentations with all the variants. When do we start seeing them as different things? Is the COVID of today and the COVID of 2019, are they the same things? When do we stop seeing them as same or as different? How come we see them all as the same? And one of the things that, some of the questions that are raised, like, lots of people weren't able to test. If you couldn't test it, did you not have it? If you have long COVID and you weren't able to test, can you get the same recognition, or do you have to go be some chronic fatigue fibromyalgia sufferer with less respect? So there's lots of things like that. I'm sort of babbling a little bit, but yes is the answer.
Kia ora, Dr. Jutel. So we'll go next with Sasha, then Sophie, and CM had her hand raised. So, and then afterwards we'll go to the public audience.
Yes, thank you so much, like my other colleague said, for such an informative lecture. I kind of had a question about what does diagnosis say about your character? I know that was a question that you kind of talked about earlier in your lecture. It kind of made me think about the pedophilia example versus kind of how people view Down syndrome. Obviously, when you look at pedophilia and that example, that's something that people kind of view as more of a character flaw. So I kind of wanted to ask you about how, from your own personal perspective, how much do you see things like that being debated among sociologists, or perhaps it might be different with sociologists versus psychologists, and how they kind of see that question, what does your diagnosis say about your character, and how that kind of differs among different types of diseases and conditions and behavioral kind of deviations from the norm.
Yeah, are you thinking, so the question is really interesting, whether it is at a individual level or a broader sort of social level, like as we talk about groups. And it reminds me of a presentation I heard about borderline personality disorder. So borderline personality disorder is often referred to as the thing which is intolerable. The patient that you can't stand has got border personality disorder, right? So that it's more about the clinician than it is about the patient. I can't cope with this person, I'm giving them that label. And I'm not an expert in that area, but there's some amazing work on borderline personality disorder and how it is a comment on character, but not, right? Like, so, and we can talk about narcissistic personality disorder or sociopathy, these kinds of diagnosis, which imply some sort of a unpleasantness. But because they're couched in diagnostic terms, does it forgive that character flaw? And then I need to think, I'm going to divulge more than I should, but I come from this really interesting sort of ignorant background, ignorant of medicine as a method of thinking. So I am an Ashkenazi Jew for Palestine. I'll say that out loud. But I am an Ashkenazi Jew. And my grandparents, actually, it was in my grandparents' generation. Great-grandparent generation. My great-grandmother Florine was orphaned very young. She had no Jewish community. Her parents were gone. And apparently, because we were a marginalized group at that point in history, and apparently a lot of intellectual Jewish people went towards Christian Science. And you guys probably know more about Christian Science than I do in some ways, because I don't think it exists in New Zealand. But my grandmothers ended up, both of them, being raised as Christian Scientists, and they believed that they were made in God's image, and therefore they shouldn't have flaws. So they would pray away their illnesses. And that's an interesting concept too, isn't it? And I can't help but feel virtuous that I haven't had COVID yet. There must be something strong about me, right? I can see you laughing, Adrienne. But it's how many in the room are novids? Like, it must be character, right? Yeah, yeah. Well, we must be better people than everyone else, right? And I don't really mean that, but there are things, and particularly in the neoliberal landscape of today, being well is a virtue. So being sick is some sort of a moral failing. There's a wonderful article by Sven Brinkmann, and he's a psychologist out of Denmark. He's a superstar. And Sven wrote about the languages of suffering. We're working together on a book precisely on this, Sven and myself. And there are many ways of talking about our problems of living, and the biomedical way dominates right now. But there's also a moral vocabulary for suffering. I ought to have, I should have. There's an existential way of talking about our life problems. There's a political way of talking about our life problems. And I think one of the challenges that I see in the way we talk today as a sort of activisty kind of person is that we'll talk about being burnt out or being stressed, but we won't talk about, we don't talk like trade union people anymore. We don't talk about the man. We don't talk about the structures that impose upon us unbearable conditions. We talk about ourselves as if something's wrong with us, or we express our anger in terms of our bodies rather than in terms of a critique of the work structures within which we're forced to operate. So I don't know if that helps a little bit, Sasha. It might not be quite the answer, but there's some free-flowing thoughts.
No, it helps. Thank you.
Good. Thank you.
Yeah, ora Sasha. I'm gonna proceed with Sophie, then CM, then the general public can actually feel free to put their question in the chat or raise their hand.
Cool. Hi, thank you so much for a great lecture. I, as a sociology major from undergrad, was very happy to hear all of this. But I kind of wanted to ask, I think one of the things that our cohort and kind of my fellow students here, we've talked a lot about throughout our program is just how to transform like theory into solution or into some sort of action, right? As we kind of hopefully end up in this world. As professionals and everything. And so I think as you hit on during your lecture, like medicalization and the need for diagnosis can be both helpful and a negative for individuals in society in so many different ways. How do you have any suggestions on how we can potentially like temper each end of the spectrum to prioritize empowering patients and, kind of, I guess, focus on spend more time with the good than I guess letting the negative bloom. I'm going
to quote one of my students. So she made this really strong point in her presentation. This is Nashin Khan last Thursday in class. And she said, advocacy is stronger when it's backed by theory. We can push for real change. This is why we're studying this stuff. So advocacy is stronger when it's backed by theory. Because I think if you can see what's happening, so I don't know, for example, if we want to go to the HbA1c and we're working in health promotion and we've got someone labeled as pre-diabetes, some of the important things are recognizing that, yeah, it's good to exercise and eat well, but it's not the numbers that guide us. Why do we believe in numbers more than we believe in patient stories? I mean, we've got a lot of theory, I know you do, behind you that can help you to understand this and then use that as your tool. You have a very famous name, Sophie, your last name, Burry. Do you know Michael Burry's work in diagnosis? Do you know Michael Burry?
Yeah. Yes, I cited it in my thesis and it was really confusing and I kept getting asked why I was citing myself, which I was not.
No. And as we say in Māori, Michael Burry passed away just a few weeks ago. I saw that on the BSA list, but he wrote the wonderful work about biographical disruption, how chronic illness, I like it. So my students tend to use that as diagnosis as the course of biographical disruption, the idea that that a diagnosis can change the direction of your own narrative. And I think really useful. So here's an example. Here's a theory. We've got this idea. Michael Burry's theory is that chronic illness disrupts your biography. Okay, you got a theoretical thing. You have a patient who's just learned they have a terrible diagnosis, and they're going, "Oh, I'm not who I thought I was." Well, actually, what you can start thinking about is how narratives work. There are many narratives by which we can tell our tales. And we don't have to use this transformative, disruptive way of thinking, because in fact, our identities are intact. And this is just a storytelling mode. It is a very common storytelling mode, that our lives are changed when we get a disease, a diagnosis, whatever. And in fact, you can, knowing this, provide stronger advocacy for thinking about the narrative forms that are available for people who are suffering or receiving some disruptive news. So there you go.
Kia ora, Sophie Burry. And we'll proceed with my last question of my amazing cohort. CM, you have the floor.
Thank you. Oh, and thank you so much for your wonderful presentation today and coming to talk to us. So my question, I believe, has been touched on somewhat, but something that we've talked about during our summer session was how culture can influence the manifestation of certain conditions. So to reference one of them, there's a group in Laos who has a belief in energy systems that's similar to Ki, where it flows throughout the body, so they'll often experience pathologies more in the neck if it relates to emotional distress. My question is, how do we as people working in healthcare and public health go about providing empowerment to people and everything that can come with a diagnosis for those who have presentations that we would consider atypical?
Yeah, I actually missed quite a bit of the question, CM, because there was a noise in my ears. I don't know if everyone else heard it. Yeah, but I think you were saying there's a variety of different presentations based on cultural positioning of the people receiving a diagnosis. Was that right? Yeah. I think the most important thing is listening. And I think that making sure you understand how people feel gives you the anchor for then doing the work that needs to be done, and being mindful that things are very different depending on where you are, and some things you will not change. So I studied my nursing in France. In France, people put scarves on when they have sore throats. I don't know. I doubt that it really matters, but try telling them to stop. I don't think that's going to work. And you go to, I don't know, in Germany, all little babies wear hats. In the Cook Islands, all little babies wear mittens. But you're not going to take off their mittens or their hats. It would be unthinkable. You wouldn't put mittens on so there are things that cannot be shifted. And I think one of the stronger points, and I'm going to be a little bit, I was going to be critical of America, and I've got this funny accent, but I was born there, generations of family from there. So I hope you see this as self-scrutiny rather than pointing a finger. But try to look at yourselves and think of all the stupid things we believe. Like I talk to my sisters and I want to shake them a little bit, but I've got critical distance because I'm in a different country and I live with a man from another country and I'm surrounded by grandchildren from islands and places. And so that's a real luxury to be exposed to different ways of thinking. And those of you who have been in other countries, particularly non-Western ones or non-developed ones, will understand that what they do there or here isn't more better, more worse. It's just different. And we cling to those differences because they are who identify us. They are what identifies us. So being careful not to be imperialistic colonizers in our advocacy work. Yeah. And there is a diagnostic reliance in the States, which just floors me. Floors me. And I have to say the book that I'm working on with Sven is how to get away from all these psychological diagnoses of normal life. Because I don't buy it. Oh, it
So,
happens here too, though.
Annemarie, I think I'm going to have to invoke our hard stop of 1:15 Eastern time. I apologize for not getting to everybody's questions. I want to thank you for doing this in the very early morning hours of your world. I hope you got at least a little bit of sleep last night, and I encourage the audience to come back for a couple talks coming up. One that has to do with personalized medicine and the genomification of medicine, and another one on social disparities and how that factors into research, because I think you're going to find that a lot of the lessons that Annemarie talked about are going to, be running through your mind as you hear about what these people are going to talk about. So come back, all of you, to hear the next couple of lectures if you can. Gerard, great job today. I'm going to give you the final word. Gerard?
Yes, I'm here. Kia ora again, Dr. Jutel. A very, very informative, very, very informative presentation. We've been introduced to your work this summer, and it was really an amazing surprise to have you in person telling us about all the work you did. And I want to again say thank you to our teachers that gave us our first class. We have Dr. Julia, Dr. Cidi here. Thank you again, Dr. Cidi. Thank you again, Dr. Myers and Dr. Fuberman. It was a pleasure to moderate this meeting and very happy to be attending many more.
Ke te
Thanks,
mihi ki a
everyone.
koe, Jero, and ke te miti ki a koutou. Thank you very much, and I really appreciated your using Māori in the lecture. Beautiful. Thank you, everyone.
Kia ora
Thank you
tū.
for having me.